The broadcast is now starting. All attendees are in listen-only mode.
Welcome everyone to today's webinar. My name is Aaliyah Martin from Health Resources in Action, specifically with the Community Health Training Institute. And today's webinar, we're excited to be able to present to you Promoting Equity Through Community Partnerships with our presenter Amanda Navarro from PolicyLink. And she will be joined by guests Risa Silverman and Zach Dyer. I just want to remind folks how the webinar will work. You are able to ask questions through the question box, which you should see in the toolbar on the right-hand side. We will address questions during the Q&A section at the end of the webinar after all the speakers have spoken. Also, I want to remind everyone that immediately following the webinar, there will be a quick survey that we would like everyone to fill out so that we can continue to improve the work that we do. And then after the webinar, within a few weeks, you will receive a recording of the slides and the presentation. So again, just to remind folks, you are able to type in questions into the question box, and we'll address those during the question and answer section. And so now I'm going to turn it over to Steve Rodini, the Vice President of Health Resources in Action, who will be helping to moderate today's webinar.
Good afternoon, folks. It's a pleasure to have you join this webinar, and thank you, Aaliyah, for helping set up this webinar. It's my pleasure to introduce a colleague and good friend, Amanda Navarro, Dr. Amanda Navarro. She's currently the Deputy Director at PolicyLink with offices in New York and in Oakland. And in her current role, in many of the roles that she plays, one of them, she is overseeing the efforts of the National Convergence Partnership, which brings together national funders and the Centers for Disease Control to look at the issues of equity from a private philanthropic and a public agency perspective. She also guides, she also provides strategic guidance, technical assistance, and training to public and private agencies and organizations on strategies for creating healthy and equitable communities. It's my pleasure to introduce Amanda to you, who will be speaking about health equity and thinking about equity through creating community partnerships. So Amanda, I'll turn it over to you.
Okay, great. Thank you, Steve, and also thank you to Judy Foley for the opportunity. And hello, everyone. It's great to be on this webinar with all of you today. So I wanted to take the opportunity to talk with you all today about equity. What does it mean? Why does it matter? Not only for our nation, but for Massachusetts. And so I'm going to actually do a little bit of setting the stage, giving some broad framing on equity. And I'm not going to dive in deep. That I'm really going to leave to Zach and Risa, who will really bring forth some wonderful local insight and experience and thinking on how to advance equity through community partnerships and policies. So just to start off by introducing PolicyLink, for those of you that are not familiar with the organization, PolicyLink is a national research and action institute that advances economic and social equity by lifting up what works. We believe that local leaders are our nation's leaders, and all of our work really relies on your wisdom and experience. So I'm really looking forward to hearing from all of you on the good work that you're doing around equity, but also what challenges and questions you may have as it relates to how do you really promote equity through your efforts. So I want to start out with, and we're going to do a few of these throughout my presentation, do some polling questions, and to help get a sense of your understanding and experience of equity and also of equity-focused efforts. So we wanted to just start out with this question. How well do you feel you understand what equity is? So if you could just take a moment to fill out the poll, and we'll just give about a minute. Okay. And it looks like there's a good range with majority of people feel like they know about equity somewhat, and some knowing about equity to a great extent. That's great. Thank you so much. So why don't we start back out onto the next. Okay. Sorry about that. Okay, so I wanted to do a little bit of level setting and just make some distinctions about the various terms that we use in our field and in our work, and I think these are just really important distinctions to make across concepts because they don't all mean the same thing, and they all don't lead to the same solution or the same type of considerations. So let's start with health disparities. That's been a term that's been around for a very long time. But the term health disparities is just simply looking at and calling out the differences between specific populations in the incidence, prevalence, and mortality of disease and illness. And it can be broken up between a variety of groups. But that's really what it is just looking at the differences. Now, equity is really going deeper than just the disparities concept by asking why are some populations at greater risk of illness and preventable deaths than others. So this question really leads to a deeper analysis and exploration of the social and economic, systemic, and institutional factors that contribute to disparities. And so the way that PolicyLink defines equity is just simply just and fair inclusion. And the four fundamental questions that we ask ourselves from the onset all the way through a process and how we do our work really fall on four questions. One is to really understand who's going to benefit from your effort, who pays or who will be harmed, who will lead, and who decides. And just to further clarify another concept, which is the distinction between, and this is an important one, between equality and equity. And if I could just give you a visual here, you know, equality is if I gave everyone on this webinar a pair of shoes. Now, equity means that I would give each of you a pair of shoes that fits. So just keep that in mind as we continue through the presentation. So why is equity important and even more important now? Well, we know that the face of America is changing and that by 2043, the majority of people in this nation will be people of color. By 2030, the majority of young workers under 25 will be of color. And by 2019, the majority of children under 18 will be children of color. We also know that particularly in Massachusetts, there's a rapidly increasing Latino and Asian population that has really defied the state's slow population growth overall. For example, between 2000 and 2010, Asian Americans were the state's fastest growing population, and during that same period, the Latino population grew by approximately 47%, which is a rate 15 times greater than the state's population as a whole. This is actually a map that we pulled from the New York Times. They created a database where you could map the change in population since the year 2000. And you see Massachusetts, and on the left-hand side, the legend there and the population changes, is that you'll see that there's quite a big jump in the change in the population among Hispanics and Latinos and Asian Americans, and where you see the decrease. So the question here is really, how do we step into this future, in a future that will look very differently than what it has in the past, and not shy away with it? And more importantly, how will we work together differently and invest our resources in different ways that will actually be responsive to the changing demographics? I think one important point to raise here is that, you know, as we have seen playing out across the country and on the national and local stage, racism continues to be a driving force that has influenced how people experience their lives and how they are restricted from opportunities to live healthy and thriving lives. And I wanted to raise this as a way to have you think about, race is in and of itself is a social construct, but we have used that construct for centuries on how to differentiate people and create unequal relations of power, which then determines who gets access and who gets opportunity. So racism, as we see it very clearly today, continues to have major effects on educational and economic opportunities, and also political and institutional representation. But we also know that where you live is a proxy for opportunity. So economic and racially segregated communities either concentrate resources and concentrate lack of resources. And this increasing concentration of racial residential segregation poses a host of problems to our communities. Not just a lack of economic and educational opportunities, but it leads to higher crime, dropout rates, and higher rates of infant mortality and chronic disease. So really the way that we need to begin to transform and think about equity is to think about the systems and the structures that we've set up in ways that has perpetuated racism and how racism reaches into the lives of people of color. And from there really come to finding ways to build an equity approach that puts people of color at the center of the work. So really the goal of racial equity is to produce fairness and justice in systems where race will no longer be a factor in the assessment of merit or in the distribution of opportunity. And this different approach really means that we have to work with communities of color, having them design programs, conduct research, shape budgets, and make decisions in a way that's really promoting equitable systems that allow opportunities for all. But also it really requires us to take a profound appraisal of how organizations are accountable to the people that we are serving or not serving, and it requires that we really change the way that we practice, the way that we do our work, and that involves enabling community members to build power and pride. So I wanted to break this up into two ways in how we talk about equity, and really to say here that equity is both the means and the end. So let's start with the sort of process piece of equity, and here's our second poll question, which is, to what extent do you integrate a racial and economic equity lens into your data collection and analysis? So we'll just take a minute if you could complete that. Okay, great. So very similar to the first question, that there's been some integration of equity, racial and economic equity, into your data collection analysis, and a third thing that you have fully integrated. So that's good. So we'll hopefully parcel out and think about, well, where are those places that you haven't thought about, and where can you bring full integration into data collection analysis? Sorry, I'm not seeing my slides up on the screen. Steve or Leah, I'm not sure if you have the PowerPoint in front of you, but I can't see it.
Yes, we're working on that right now.
Okay, so why don't I continue and just briefly make some points about data collection analysis, and hopefully we'll put up the questions in a second. But just to say that, as we think about data collection analysis, what I continue to see, which is pretty surprising given that we know that there's major demographic shifts happening across the country, that data, the way in which it's presented, really does not look at the differences of indicators by race, ethnicity, and nativity. And so who is most impacted by these inequities, and really looking at disaggregating the data by race and ethnicity is really important, but also really overlaying that with where are those inequities most severe, whether across the state and in particular in local communities. But I think from a data collection point of view, broadly speaking, is also really thinking about, well, what learning has come from community residents? There is, I find that when you talk with community residents, they can very quickly and aptly tell you what are the most deepest inequities and problems happening in communities. So how does that relate to the data that you're seeing, and how can you think about what you're hearing from communities as a way to really drive your strategy development? And so I was going to show a couple slides that looked at different examples of what equity indicators are, and I think one other thing that we, to consider is not just looking at health outcomes like BMI or diabetes, or even looking at nutrition and eating fruits and vegetables, but what are some of the equity indicators that really get to the root causes of these health disparities? So one has been PolicyLink. We've been looking a lot at economic indicators, and in particular, not looked so much into high school graduation rates, but have been looking at associate's degree, because we actually know that economists are saying that jobs in 2018 are going to require at least an associate's degree. So that's almost half of our future jobs will require an associate's degree. And if you look at the data, it will show that the lowest percentages of those that have an associate's degree are Black and U.S.-born Latino, as well as immigrant Latino populations. So you've got Black with 27%, U.S.-born Latino 26%, and foreign-born with 14%. And so that really just, I think, is another way to be able to say, well, how are we ensuring that those youth in our future are really providing them opportunities to become part of our workforce? So I also see here from the poll that the results from the question as to what extent do you integrate a racial and economic equity lens into your community partnership, overwhelmingly people have said somewhat, and that is a great result. And I really would be curious to hear from folks what do they mean by someone, and where will they be places where they feel that there has still been some challenges on how to fully integrate an equity lens into community partnerships. Great. One other indicator that, again, really thinks about the future of our youth in really creating economic and education opportunities and growth for the country is this indicator of disconnected youth, which essentially is looking at youth between the ages of 16 to 24 that are neither in school or have a job. And as you can see in Massachusetts, you have quite a large percentage of Latino and African American youth that are not connected to either a job or education. And on the right-hand side, you see where there are places, the neighborhood clusters that have the highest rate of disconnected youth. So this connection between race and place is really important when you start thinking about how do we start addressing equity in our communities. I wanted to quickly lift up a resource that PolicyLink with the university, with USC's Program of Environment and Regional Equity, we developed the National Equity Atlas, and this is a comprehensive online resource that puts data on demographic change racial inclusion, and economic benefits right into the hands of anyone that is really interested in seeing what the state of equity in your region is. And we have in the database, you can access key indicators on the largest 150 regions across the country, as well as the DC area and the nation as a whole. And the atlas actually allows you to look at data and charts and maps and gives you some policy ideas and also examples from across the country and how communities have been using this data as a way to drive policy change. So one last quick point around the data piece is that one, and this actually leads to thinking about your community partnerships, is to really dive in deep and do an analysis about how are your internal structures in your organization either promoting equity or perpetuating equities, and how are you holding yourself accountable to making sure that you're promoting equity and holding your partners and others accountable. So here's sort of the different pieces of the pie that you can really think about, well, you know, what are conflicts that we have internally that we really need to start thinking about differently to ensure that we are in line with delivering on equity, whether that's looking at how you collect data, how you analyze and interpret the data, looking at structural conflicts like who has power and authority in the organization, where's the control of resources. As I mentioned, you know, budgets are one of the most powerful tools to support equity or actually create inequities. So really looking internally on what are ways that you can actually change your systems and your policies and practices is really a great first step. Wanted to talk about, and this is part of the community partnerships piece, that another critical component to achieving equity is around community engagement and leadership development. And so part of, I think, that we have found an experience where there has been the greatest challenges in creating authentic partnerships has been, in several ways, a discomfort and hesitancy in really coming into the space of acknowledging power dynamics between those that have a formal position of power versus community members, and also really squarely confronting and addressing issues of race and culture and class. The third pitfall, I think, has been really not being clear on the distinction between outreach and engagement, and understanding that outreach is not engagement. When you have created a plan or a proposal that has not had community input from the beginning, is not engagement. Engagement is ensuring that you have community residents right along with you in developing your strategy from the onset. But of course, this also requires, and we hear this a lot, that, you know, really understanding, does the community trust you? Does the community trust your organization? What has been the perception of the organization in the communities that are most impacted by health? And that may mean having to slow down a process to rebuild that trust. And of course, most importantly, is to be intentional on inclusion, making sure that people feel that they are included in the process, they're included in the meetings, and that the meetings and convenings and gatherings and how you develop this, your effort, is accessible, and of course transparency. Being really accountable to letting others know what you are expecting of them and what they should be expecting of you. So I wanted to jump to this slide and just to show that this is actually something that PolicyLink developed to really look at, and I'll use a food metaphor here, which is, you know, I think part of community partnerships and community engagement is not only ensuring that you have a way to collectively set the menu and bring those that you want to the dinner table, but also questioning and really looking at what kind of table are you creating. And so I think that we, you know, while the town hall meetings and focus groups are valuable and certainly of use, that when you think about the table that's being created, think about sort of the the picnic folding table where you set it up, you have people come, and then when you're kind of done with collecting your information, you pack up and you go. That's not necessarily a sustainable structure to ensure that community members are actually institutionalizing and putting voice to decision-making processes, which is then when you go up the ladder at the governance level where you have community residents really appointed to decision-making boards and commissions. That's where you start seeing real shift in power and real ability to bring voices that have been marginalized to the forefront in changing how decisions are made. So this is our last polling question, and this is very similar to the first two, but we're going to shift gears to not just the process, but really specifically looking at policy change. So to what extent have you integrated a racial and economic equity lens into your policy strategy specifically? So we'll take a quick 30 seconds on that. Okay, if we can have the results. Okay, great. Very similar to the others. The majority saying that somewhat of you integrate a racial and economic equity lens into your policy strategy, and a smaller percentage of you say fully integrated, and some of you actually say none at all. So that's really interesting. I'd love to hear more about that. So let's talk about, the equity and policy piece. And as I continue to talk while the slides come up, when we think about policy change and really changing structures, we want to really think about upstream strategies. So, you hear a lot about downstream and upstream, but essentially what it means is that when we look at the downstream measures, which is really programs. So how we increase educational services for Latino families and provide health fairs and health curriculum to families. That is a downstream strategy. Provide something valuable, that's information, but that doesn't necessarily change the systems and the structures that are supporting people to actually make healthier choices. And I'll just share one quick story, which is I am trained as a public health professional, both my master's and doctorate, and the very first time I was working as a research assistant and doing interviews with women actually in Boston, Latina women. I was taking my training from the public health school, and at the time it was really about educating families on how to eat healthier. And I remember a woman, a mother, saying to me, hearing a lot about what I need to eat and having that point continuously being made really actually makes me feel really bad. And I stopped and I asked her why, and she said, well, it's not because I don't want to, but it takes me 2 subway trains and a bus to get to the closest supermarket where I can get fresh fruits and vegetables. And so I raise that to say that in and of themselves, educational campaigns and programs cannot really lead to the support and the safety net that people really need to lead healthier lives. And so that's why we want to focus on the upstream, that how do we change decisions that affect communities that are most burdened by inequities, and actually not even the decisions, but ensuring that those decision-making structures and the way that decisions are made is actually ensuring that people that have been most impacted by inequities benefit from those changes. So really getting to this idea of advancing health and equity in all policies requires that we look at strategies that have multiple benefits, that they improve the health of people, they revitalize neighborhoods, and they create good jobs. So here's a list of policy and economic strategies that support health, and I think we all know these pretty well and have been working on these, but just to say that on paper or on screen, as these, in and of themselves, these do not address health equity. And in order to address health equity, think about the shoe. In and of themselves, the way that these may be structured may not be a good fit for a particular community. And so our job is to look at, well, how does one policy strategy, how do we make sure it fits in a rural community, in a urban Latino community, you know, and ensuring that we actually get the right size shoe for each community. So I'll leave it by saying that equity really requires us to innovate, to really look at different ways to approach a problem, and it just means testing and experimenting and working with communities in ways that really looks at things very differently and tries things out. But it also requires us to take what we're doing already and refining it, really taking a much closer look at what we have and how it really has or is not advancing equity and making appropriate adjustments. And lastly, it really requires us to change our behavior, change the way that we think, the way that we do our work, and the way that we really, truly engage with others that will advance our agenda on equity. So with that, I will actually turn it over back to Steve.
Thank you, Amanda. And again, for folks participating in the webinar, please feel free to be submitting your questions, and then we'll get to those after Zach's presentation. I'd like now to present Risa Silverman. Risa Silverman coordinates the UMass School of Public Health and Health Services Outreach Office. She worked with a team of partners during the fall to successfully organize the first Western Mass Health Equity Summit, and she's currently working with a group of stakeholders to identify some regional policy issues and develop a long-term action plan to address equity issues in Western Mass. So it's a pleasure to have and welcome Risa.
Hi, everyone. Thanks, Steve, for the introduction. And there's my name and contact information on the slide. And I am here to talk to you about the very new Western Mass Health Equity Network that is really just forming out of the Western Mass Health Equity Summit that we held in October of 2014. So I'm going to talk to you a little bit about how we've been organizing ourselves the last couple of years. How we got started is in my role at UMass as the outreach person. I've been fortunate for the last almost 20 years to meet a lot of the amazing community health leaders in our region, which is the 4 western counties of Western Mass, so lots of cities and towns. And we're sort of furthest from Boston, or we feel furthest from Boston, and so we are naturally sort of a unit of the western counties. And the dedication to the communities that our leaders show often blows me away, and I thought if we could all get together, maybe we'd be able to come up with a way to build on each other's strengths and address what's been so talked about, health inequities and social determinants of health. And I know there are at least a few people on this call who were part of the entire planning process with me, and so I wish they could jump in with me, but I'll try and represent what we did. So we organized, about 20 of us got together at one meeting, and that was not quite 2 years ago, and we started the long road that many of you know through the wishy-washy territory of what would have meaning for each of us, what would make it worth our time to keep meeting, and might lead to lasting change and a more just and health society. That's all. We had another 50 people come in and out of meetings. We tried to do some outreach to the furthest points of the counties because even in Western Mass there are parts that are further and closer. And at the beginning we called ourselves the Health Equity Regional Work Group. And I look back on our notes, and early on we set about to define health equity, similar to what Amanda spoke about, to build a network that could advocate on a regional level and develop a regional voice in the Commonwealth of Massachusetts, and also really to look at how data could be applied using a health equity lens and to sort of skill build for all of us about how there seems to be a lot of data out there, but how can we utilize it and also make it more effective to attain more equity in the region. So one of the first things we did was actually discuss and define inequity and compare it to what disparity means, just like Amanda described. And I just remember really enjoying taking that time with everybody in my communities to contemplate it because sometimes the jargon is like, yeah, I think I know what that means. But we really sat down and dissected it and came up with a definition we would all work with and invite others to talk about with us. And I just remember that was a great time of reflection, which I think all of us can use that time of reflection because we don't get to in our daily work lives frequently. Another really key thing that we felt we could organize around was the fact that the Affordable Care Act was now making hospitals do a needs assessment in all our communities every 3 years. And we thought as a group, well, that seems like a natural, doable, achievable goal. How can we get more of our voices, our community voices, involved in creating those needs assessments, asking questions that will get at inequities, and to be able to gather that data and have that data come back to us so we could all use it more effectively, again, to work on equity issues. So that really was sort of a rallying call for us, and we educated ourselves. We had our 2 area hospitals come in and do a session with all of us, and we thought, oh, this is great. We really have to share this with more people. So all of that energy led us to come up with what we thought we would do next. We even considered having an unconference, which is something that I know some people might know about, but we decided to have a conference, a summit in October of 2014. And some of the things that I think helped us along was that we had no money on the table at the beginning to confuse our goals, that people really showed up for months before we decided what to do, and so we could really figure out what had the most meaning to us. We took 1.5 years to plan and carry out this event that we held. So I think it led us to be a little bit more thoughtful and enjoy the process and perhaps not be overburdened. And someone said the other day, it's like health equity is everyone's work and no one's work. I don't know if Judy Foley said that, but I felt like every moment as an organizer, I didn't want people to feel so overburdened they couldn't participate. We raised over $40,000, which helped us do some follow-up activities that I'll talk about in a minute, but it also let us keep our registration costs super low and be open to non-professionals who wanted to attend at low or no cost. And we committed from the beginning that the event we held would be a stepping stone, not a one-time event. So we kept holding on to that, and that's what hopefully you'll hear in my ideas for the future, that it was one step in the process. And we had a really fabulous steering committee with the Mass Public Health Association as a great partner, and 2 people from the Mass Department of Public Health, Bay State, our region's largest hospital, Mason Square Health Task Force, Springfield Department of Health and Human Services, and UMass. And we then had another 20-plus planning committee members. So it was just really exciting to see who wanted to come out and participate in this creation. So we did come to this day last October. We had over 330 people, and I just remember the conference services planning people could not believe that a first-time conference could have this many registrants. They just couldn't believe it. So, and I was like, well, it's health equity, and also Western Mass is really amazing. So it was a really exciting day, and I know that one of the state representatives, she's like, I never saw so many people of color in one room in Western Mass, and I felt like excited by that and feeling like we were really building something. So I'll just say a few things about the day that I thought were helpful. One, we had Amanda Navarro do our keynote. And after her piece today, I'd say I'd like to have Amanda before each and every conversation about equity takes place, because it's really helpful. And I mean, I learned again today, it's so helpful to trigger these thoughts and ways of acting to work on this. Another element, we had a panel, and Steve Rodini, I give him credit for this because he helped me figure out that we didn't want to just have a hospital and an urban health department, which we did have on the panel, but we had the Hilltown Community Development Corporation, who they work on housing and health, and they're a great partner. We had the Planning Commission, the Pioneer Valley Planning Commission. Again, they do lots of data collection. They're looking at equity issues, and the Anti-Poverty Agency Community Action, that we are all speaking about a lot of the same things, and it helped us realize why aren't we working together all the time. Our languages are similar and our goals are similar, and equity is at the forefront of a lot of the work. So the panel was really exciting. We didn't have enough time for it. There's a lot of follow-up we could do in that arena. We had a creativity corridor because we wanted to include history and culture as part of the summit, and so we created a call for work that addressed health inequities, but creatively. So we had a wonderful display of body maps and photo voice and digital storytelling to showcase these alternate forms of communication about health issues, many of which involve young people and community members in their production. And we also had some planning members who creatively developed skits to demonstrate some social determinants of health. They involve conference attendees in writing and acting in these skits, and that, talk about fun. It's fun to see our colleagues and friends up on stage. And we also had food, as usual, but because we raised enough funds and because we were talking about equity, we were able to prioritize the equity issues in the food we served. I met with UMass Dining Services, and they were able to work with 2 area food justice organizations to purchase their produce for the luncheon, Nueces Raíces and Gardening the Community. And they were also able to make it as locally grown as possible. So it was a way to serve up a delicious meal that had a connection to local, sustainable, and just food. And I feel like we raised a lot of money from the hospitals in the area. And I just feel like as we prioritize equity, we have to show that equity costs in that way. That's just one example of many costs in a good way. So finally, at the end of the day, we asked some questions that gave us a lot of data to work from. Most particularly, what would success look like to you in terms of this being a stepping stone? I can't summarize it here, but it ranged from everything you might imagine topically, some of the issues that Amanda put up, transportation, economic development that promote equity, but also process, like raise up our rural voices and use racial equity language. So we have a lot to go on, and some of the ways we're moving ahead, we're trying to do some short and long-term planning so we don't lose the 330 people's energy, is that we are going to work on developing that Western Mass regional voice on shaping health policy in Massachusetts, and now we have a partner with Mass Public Health Association to help us create this path. So we're going to host a gathering and do an online poll in March to identify which parts of the Mass Public Health Association's policy agenda we in Western Mass support and want to work on. And then we'll identify those priorities, figure out if we can do some sort of a campaign and involve people and skill build at the same time to try and make that something that has meaning to different communities in our region. We're going to continue to work on those connections between health and the other sectors. Just going out and meeting and talking and connecting, making those connections with education, housing, employment, and economic development in our region. And then the third is working again with the needs assessments the hospitals are going to do to make sure that that does involve more community voices and also support health equity efforts linked to racial justice. And finally, we have to balance in our region rural health equity concerns as well as urban concerns, so figuring out language and strategies to do that. And I liked Amanda's phrase of racial and economic equity lens, because in our region we have some racial equity cuts across all regions and economic equity issues, and they vary in the way that they're understood. And so just figuring out language to understand that is really helpful. And again, I like also, Amanda, you're good. When you said enabling communities to build power and pride, I feel like a lot of people and leaders are doing that. And then if we can do that in a unified way and make some lasting change, that'll be really exciting. I just was asked to talk about some enablers towards this conversation on equity right now. And I think in Western Mass, we have a lot of organizations trying to look at health inequities and root causes and those upstream issues. But it's not so easy, as we all know, and so I think finding each other and building on each other's work when possible and working on some policy and practice changes together when possible can only be of benefit. I think another enabler is that the social determinants of health gives us a common language and it allows people in the field to get at and discuss root causes as part of their work. And the fact that the ideas of inequities are more explicit and spoken, it feels like it's more possible to address. If there's a language, there's graphs there's ways to really approach it, and so we can make those changes we want to make. Another enabler is I think that the non-public health leaders also want to make this lasting change. They're going to be great partners, and the idea of working across traditional silos is exciting for all of us. For our region, we have a Western Mass legislative delegation, so organizing as Western Mass for advocacy purposes can make a lot of sense. And we think showing common issues across rural, urban, and suburban communities can be beneficial while trying to tackle policy changes. And we have great partners with MPHA, as I was saying, applying their expertise to our region. And we have started to work with Robert Wood Johnson because they have some free technical assistance with their county health rankings and roadmaps, and talking to Steve Rodini at Health Resources in Action and talking to all kinds of resources that are out there has been really helpful. And I know that we'll be looking at the National Equity Atlas that Amanda just showed us, and that Wheel of Conflict for sure is. We have a Facebook page. We're really new, but putting this out there and also saying we can do this together, I think is a good message. And then some barriers, nothing new, but the systems and funding that keeps us from working together to address root causes of poor health is a barrier that I think we're all very excited to overcome, and I think this gives us a path to do it. Inequitable policies and practices that we have to identify and uproot, and I think seeing each other do that, again, is really helpful. We're just at the beginning, and so we need to keep developing a plan and have good long and short-term goals to keep our region connected. So anyone on this call can contact me at any time if you want to help us do that. And our geography is beautiful but challenging in its diversity and distance from Boston, so those are some barriers that we contend with. And I think that what's different now is that everyone's thinking about and understanding and placing energy and resources on social determinants of health. And many of us have for years been wanting to look at root causes of a community's high rate of diabetes, for example, but the discussion has frequently focused on that one person rather than the entire picture, a picture that looks at the policies and practices that need to be changed for that person and that community to thrive. And again, just please be in touch if you are interested in working with us in Western Massachusetts. Thank you.
Great, Risa. Thank you so much for a comprehensive presentation. And it was exciting to be part of the summit. And many of us who are doing this work in the eastern part of the state, it was wonderful to turn to Western Mass to learn how you all put together such a comprehensive and well-attended and enthusiastic summit. And it's great to hear some of the things that are coming out of that summit. So thank you, Risa, for sharing kind of your experiences and your learnings. Next, I'd like to introduce Zach Dyer, who's the Coordinator of Chronic Disease Prevention and Partnerships at the Division of Public Health at the City of Worcester, Mass. Zach's responsible. One of his roles is responsible for implementing the Greater Worcester Community Health Improvement Plan. As Risa alluded to, in terms of hospitals and health departments doing assessments and plans, this CHIP, or Greater Worcester Community Health Improvement Plan, is something that Zach is responsible for. And what I'm excited to hear him talk about today is one of the explicit goals of this plan is to engage young people and adults in Worcester and some of the surrounding communities to systematically eliminate institutional racism and the pathology of oppression. We've done many of these assessments and plans over the years, and what I'm excited for you to talk further about, Zach, is Worcester thinking about this more than just a cross-cutting strategy as it relates to equity, but a priority as well. And so I'd like to pass the microphone over to Zach to share what's happening in Worcester.
Great. Thanks so much, Steve. So I think the best way to talk through this is to explain the process that we went through to establish a community health improvement plan and how that really changed and shaped the way we think about health equity and the work that we do. So we went through a process called MAP, Mobilizing Action for Planning and Partnerships. And it's a CDC and NACHO collaboration, and it's a process that goes through 6 steps to getting through a community health assessment and community health improvement plan. And if you show the next slide, we can, there's a little visual of that. So the MAP assessment, and I think a lot of people across the country are now using MAP for the hospital mandated community health needs assessment and also their community health improvement plans. But we saw it as an opportunity not just for that one plan, but to really institutionalize this process into the way that we work. And while the process doesn't necessarily address health equity explicitly, going through it once to do our first community health improvement plan, and through that process, we saw the benefit that it had in engaging the community and engaging partners, not only for the process of developing plan, but for lasting partnerships. And we've taken this process not only to our community health improvement plan and writing that, but across all the strategic planning that we do in the department. we are going through the process again to do a new community health assessment, and we're sticking rigidly to this process. We're going through a mental health assessment across our region, and we're doing the exact same process. We're reaching out to the community to do focus groups and key informant interviews, and to get out to community events, and to have conversations and engage the community in the plans and in the process, so that no one is left out of the planning process to begin with. And I think that's such a critical step for us. We're working on a youth strategic plan as well, as the Youth Opportunities Office is out of our department now. But everything that we're doing, we're really committed to a formal process to engage the community. And I think when we first talked about this and decided that there was something that we were going to do, it felt a little strange to say, well, how are we addressing health equity? How are we engaging the community? Let's adopt this kind of formal, rigid process. But I think without that, it's easy to say that in your process and going ahead and doing a strategic plan, or in addressing anything that you're planning for, it's easy to say, well, is it really necessary to do this next focus group? Do we really need to reach out to this community? And we didn't want that option. We didn't want to ever have the easy way out. So this is something that everyone in our staff has been trained on, and that we can use this process for everything that we do. And we found it really an incredible tool for engaging the community, and for getting everyone, not just our staff, but our closest partners who go through these processes with us, like the local hospitals and health centers, to buy into this process, so that the entire community is committed to it. If you go to the next slide, we'll look specifically at our current community health improvement plan. We're in the third year of implementing this. It's the 2012 plan. It goes from 2013 through 2015. And while we were developing it, there are a lot of strategies that came out that are national best practices for promoting health equity. There are things in there like mobile farmers markets, joint use agreements, increasing community health workers, tobacco-free housing, which are all, if you look in the literature, they're all things that are supposed to increase health equity, decrease health disparities. But I think what we were seeing was that all these strategies that we are very committed to, and we've seen a lot of success with over the last 2 years, they're addressing the results of inequity and not necessarily the causes of inequity. So because of the engagement that we had through the process, the people who were sitting at the table while writing this plan said, we really need to address health equity and health disparities as a separate, what we call domain, a separate area of the community health improvement plan, so that we are addressing it explicitly, and having those important conversations across the community. So our whole fifth area of our community health improvement plan, the first four being healthy eating and active living, behavioral health, primary care and wellness, violence and injury prevention, the whole fifth area is health equity and health disparities. And that was really important for us, because it's one thing to say that we are committed to the work, and it's another thing to put it into what we consider our strategic plan for our community health office. If we look at the next slide, it shows what the goal is of Domain 5 specifically, or it shows Domain 5, the entirety of it. So this shows what our goal is and what our objectives are. And I think the language that we used, we weren't shy about it because the community wasn't shy about it. We said our goal is to improve population health by systematically eliminating institutional racism and the pathology of oppression and discrimination by promoting equitable access to and use of health-promoting resources in the community and significantly reducing the structural and environmental factors that contribute to health disparities. Aside from being a very long sentence, that goal is something that our staff thinks about every day in their work, because it's something that's built into the plan that we have committed to. I think it's incredibly important for communities and departments and institutions that go through this process and who are working on reducing health equity to make it explicit, to say that it is name exactly what you are doing to address it, and to make that not only explicit to leadership, but a culture within your organizations. And I think in doing this, we were able to do that. Part of this, the objectives that we have in here are to, first, to change policy, to implement 2 city-level policies that would reduce health disparities. The second is to increase the capacity of 100 grassroots adult and youth leaders, which is holding trainings and establishing learning communities for the people who go through those trainings. And beyond that, to do similar trainings and similar engagement, leadership development for 20 cross-sector institutional leaders. So that we have institutional leaders who are trained to engage in this discussion and to address institutional racism and institutional oppression within their organizations. And then we also have grassroots adult and youth leaders within the community who can have the same conversations. And what we're trying to do is establish means of communication and a common language for people to use to make progress on this really important work. And it's not easy work, and I think we see that every day when we're doing this work, that it's very difficult to have these conversations with people. It's very difficult to address institutional racism within your own organization, but it's work that we saw as critical and the only way to make lasting change in the other 4 areas that we're talking about. If we really want to improve community health, having a mobile farmers market for the next 5, 10, 15 years won't mean much if we're improving the neighborhoods that people are living in at the ground level as well, and making sure that jobs are, there's equity in job access, and everything that contributes to inequities at the root level, that we also have to be able to address that and have leaders across the community who are engaged in that discussion. The final area of this domain is to ensure that all the other areas are explicitly addressing oppression and discussing social determinants of health, and that is something that the people around the table who are engaged in this conversation when the plan was being written felt was incredibly important, not just to have strategies that address health equity and health disparities, which all the areas do, but to have an ongoing discussion about why those strategies are in there, how the community is engaged in the implementation of those strategies, and to make sure that best practices are shared between the people who are doing the work, so that the people who are working on health equity, the people who are working on healthy eating and active living are sharing their best practices for engaging communities of color, engaging low-income communities with the people who are doing the work in other areas like primary care and wellness. I think if we go 2 slides from here, we saw that in the last one. So I think the biggest enabler that we had in being able to get to this point where we can have those candid conversations is that for the past, since 2007, which I guess is 8 years now, there's been a Worcester Partnership for Racial and Ethnic Health Equity, and you can see all the different organizations who are involved in that and who regularly attend those meetings and engage in the work. It's a robust partnership. It's a strong partnership, and I wasn't a part of it when it began, but our director was. Some of the other people who are very involved in the Community Health Improvement Plan were, and they really laid the groundwork for having these conversations across not only institutions in our community, not only within the city, but with engaging those conversations with community members. And I think if that work hadn't been done, if those difficult conversations hadn't been done to get everyone on the same page about social determinants of health, about our values in the healthcare system, I don't think we would have been at the point where we had where we went through the community health improvement planning process to have that in there, to really do the explicit work and to feel comfortable doing that. As far as challenges or barriers, I think if you look at the, I think there's only one more slide. This is a really important conversation that we've had in talking about barriers and challenges in doing this work. I think it's been incredibly important for us to work with community organizations, small community organizations, organizations that are owned and operated by people of color, and not just the institutions that we are used to working with. And I think there are definitely challenges associated with that. A city government has a lot more resources and a lot of rigid structures and processes that might make sense to other large organizations, healthcare institutions, for example, but that create a burden for smaller organizations, so that when we're talking about projects or grants, we can't say, well, every organization around the table has the capacity, the same capacity to go through these processes like budgeting, and go through these processes like of the contract system with the city, or the PO purchase order system with the city. That there are some barriers there, and it's not necessarily about making sure that every organization that is around the table gets the same amount of resources or time from us, but really making sure that everyone has the opportunity to contribute the same amount. And I think that's what this illustration is getting at, that we see it as our responsibility, we see it as the community's responsibility to empower the organizations that do not have the capacity to address things at the same level that long-standing, old institutions, they don't have the same capacity as them, and it's our responsibility to make sure that they can still do the important work, can still contribute in meaningful ways, and that might take some extra resources, that might take some time from us to provide support, but that is really what we are striving for in a community where all organizations, whether they are multi-million-dollar healthcare organizations, whether they're small 2-3 person staff, community organizations, can all contribute to addressing health equity, health disparities, and improving health across the community. And it's definitely not an easy thing. And I think another huge, what was once a barrier but is now an enabler, was internal staff training. That once it took us all being on the same page, all being able to have conversations with each other about racial and ethnic justice, about social justice, about health disparities, social determinants of health. Once we were capable of having those conversations internally, and we're constantly working on that. It's not something you can just say, check, we're done. We all feel comfortable with this. But once you get to that point, it's a lot easier to then do the work. It's a lot easier to work with community partners and having those conversations. But it takes a lot of time. It takes explicit commitment to it from all levels of leadership, and I think that's been a huge enabler for us as well. That we have had leadership that have backed this work from the very beginning of the Community Health Improvement Plan, and I think it's made it a lot easier for us to do the important work. And I think without that, we wouldn't have been able to do that nearly as well. And that's it for me.
Thank you, Zach, for sharing that with us and sharing about the process and sort of where you all are in the process of implementing your Community Health Improvement Plan and your plans to continue using some of the processes and some of the lessons learned thus far in your work. I'd also like to just thank all of our presenters, Amanda Navarro for setting the stage, and both to Risa and Zach for giving us examples from their own work in different parts of the state. We're now going to move into our question and answer time. We have about 20 minutes to do so. but because I know that some folks may have been sitting at their desk for a while, I invite you to take a step back from your desk and do a quick stretch just to keep the blood flowing within you. And as we do that, we'll get ready to go into our questions and answers. So we did get a couple of questions from folks in the audience, which are really great questions. And I'll ask this first question to all of our presenters. We have a question here that says, when working to include disenfranchised community members in decision making, it can sometimes be hard to communicate the process and establish trust. Do you have any insights on how to do a better job at that? And any one of our panelists can jump on the line to be able to address that.
I can start. This is Risa, only because before the work that we started here, we at UMass started something called the Springfield Holyoke Health Alliance for Research and Engagement, and we spent a few years together with Springfield and Holyoke communities. Anyway, having communities able to talk about, to discuss that trust, like especially with the university, not especially, but community partners and universities often have that come up, and to make room for the distrust to be discussed and the history of that took, I think, was a really important step, I know, for where I was coming from and in our community. And I think it was partly a stepping stone to where we got with our health equity work, or I think that might be true. So I think being able to have it named and spoken and discussed openly was a helpful step in my community.
Yeah, this is Amanda. I'll build on that. And well, I just wanted to say a couple things just to build off Risa's point, which is, in my experience, there's, I think, a few first steps that are very critical. The first is just going through a collective, like, visioning and principles process. So together creating what are the principles that the coalition or the group will operate under. And it may be everything from defining accountability, defining transparency, mutual respect, dignity, and freedom. There's just a number of ways that and principles that you could put forth that will ensure that all of the individuals in the group are very clear about how to operate and how to interact with one another. I think that one of the more powerful ways and related to the principles piece has just to set up an agreement. And it doesn't have to be a formal agreement like an MOU, but it is a set of commitments that are very clear about what people are committing to, what are they responsible for, and what's the type of space that you want to create to have conversations and dialogue and to be able to do work together. And part of that is ensuring that there's a shared leadership model that's put in place so that you don't have the same people talking. And there's various strategies of ensuring that that doesn't happen, you know. And I think one big question that always comes up when you start a coalition or group is who has the mic. And many times the same people have the mic. And so I've actually recently seen a strategy where people get 5 like fare tickets, like drink tickets, and when you're up with your 5, you're done talking. And it has actually worked pretty well. So there's different ways to be able to create space to allow everyone to talk. And I think that that also requires a very strong facilitator if you choose to have someone to facilitate the conversation, and that the facilitator is not someone that is from an institution, that it's actually someone from the community that's helping to guide and moderate the session and ensure that it's the discussion, ensure that it's moving forward. So I think shared leadership is very critical.
Zach, did you have any other
This
thoughts?
is Zach. I was also just going to say, I think one of the struggles that we've had is we will invite someone to the table, they'll come for a meeting and they won't come again. And we've tried to figure out the best way to address this. And I think what we found is that, our meetings are, they're not always the most friendly spaces to come to. There's an agenda, and there's, people don't necessarily feel comfortable speaking in that space. So what we've started to do is when we invite people to the table, we meet with them one-on-one, whoever's doing the inviting, to kind of walk through, what the space is like for them, so that they feel more comfortable once they get there. And I think that's been a huge, an important step that we've taken to make sure that we're engaging communities who don't necessarily feel comfortable in an institutional space, which really is what these meetings look like.
Thank you. I do want to just invite everyone else, if you do have additional questions, please feel free to type them into the question box and we'll get to it. Another question that we have here is that someone says, it would be great to do a community power analysis versus a needs assessment. And specifically, Risa stated, sort of in quote, how we will decide. How do you get feedback from a community, and sort of what is the difference between outreach versus community engagement? And Risa or Amanda, you can go for it.
I think Amanda said it well about, this is Risa first, just saying, oh, we're having this event, come, would be some sort of outreach, or making sure the flyer is in Spanish, but engagement would be hopefully shared leadership from the beginning, and having people involved from the beginning. So that would look more like engagement. But I'll just take a stab at the question, then Amanda can add. But I think when I'm thinking, and I was even thinking about the language I used when I talked about the needs assessment the hospitals had, because talk about institutions, I mean, I work at one at UMass, and hospitals are these large institutions, so how can we be engaged versus be just informing the hospitals? And so I think part of it is looking at the process and getting involved at the beginning, engaged at the beginning, and seeing if there can be authentic community engagement at the beginning to figure out how to do the needs assessment. I mean, I love that idea of a community power analysis alongside or instead of, but whatever it's called, who creates it is what, and then what will the outcome be is what is really significant. And so I'm not sure it's going to be that easy a road, but I think that trying to start from the beginning and changing how it starts is one step. That's my first answer.
Yeah, I think Risa is spot on. I mean, I think it just requires us to really be conscious and and acknowledge how we have and this question around like who's really leading. So I think we tend to be in positions where we provide input and we start developing agendas or proposals and don't take the time to just, I think, step back or step aside. And, I actually raised this on a coalition call a couple days ago, which is, really asking yourself, like, when do I really need to step up and when do I need to step aside? And I think that's the real question around engagement, is stepping aside to allowing those that have not traditionally, historically led a process, led a conversation, to be able to do that, and to lead the process in developing what that looks like. And as far as the power analysis, I really appreciate the question and the idea, and I think, when we talk about needs assessment, I think we do fall into this place of, and when we even talk about health disparities and inequities, we just automatically go to this space of deficits. and we don't acknowledge the assets. And I do think there's a need for us to be very also conscious in acknowledging that even in communities that are, on the data experiencing deep inequities, there are powerful and a wealth of resources and human and intellectual capital there that has been untapped and has not been really allowed to come out and be lifted up and supported. And so a power analysis could really help to ensure that communities and groups as a whole really understand who has the power just because they're part of an institution and it's a formal position, and who has power because of just who they are in the community that are informal positions of power and influence. And then also mapping and documenting the various assets and resources that are very much in the community that do not get recognized.
Thank you. Another piece, sort of following up from that, we have another great question, which asks about diversity and equity. And the question reads, by increasing diversity among staff and coalition members, is one working towards health equity?
That's a really good question. And yeah, I think the wording is very important here, which is diversity is the first step towards equity. It is not. Diversity does not equal equity. And so I think just to the previous questions around bringing people to the table is one thing. Making sure that they feel included, respected, heard, acknowledged, that they are contributing to a decision and a process, and that the outcomes are really to ensure that opportunities are given to those that need it the most. That's where you get to equity.
Do any other folks have any other thoughts around that? We have, go right ahead.
I was just going to add that in terms of our fledgling network, we have put workforce development as another component of health equity. But I like what Amanda just said, that it doesn't stand alone as doing it, but if the staff reflects the community, that's one step towards what we are trying to achieve.
We have an additional question. This one is specifically about some of the work that the folks in Worcester were doing, or are doing. And the question is, did the Worcester folks participate in the People's Institute for Survival and Beyond Undoing Racism training? And if so, how did that play out in any of the work that followed?
We did. In fact, the Worcester Partnership for Racial and Ethnic Health Equity, its major role, its major work over the past several years has been to host that training every year and invite 30 different leaders from throughout the community. So I think a good portion of our staff has been trained with that training. There are people throughout the community, I would say probably around 100 different people, leaders throughout the community. Anywhere, by leaders, I mean it could be youth leaders. We had a cohort of, I think, 20 or 25 young people go through that training specifically for, like we call it Youth Undoing Racism. And then I think there are probably at least 75 institutional leaders who have gone through that training as well, and that's been incredibly important for us. And we are, again, this year looking at 2 to 3 trainings within our community for key groups. So it was doing a training, and for those who don't know, the People's Institute training is a 2-day training, 2.5-day training, and is very intensive and does a community power analysis of the people who are in the room, and I think is a great base to build this work off of. and it's been incredibly important for us, and we are committed to seeing that training continue in Worcester.
Thank you, Zach, for sharing that information. We have about 5-10 more minutes left for the webinar, so we'll probably get to 1 to 2 more questions. A question for all of our panelists is, for those who are wanting to start this work, what advice would you give to peers in other communities who are just looking to begin this work? What are sort of the lessons learned and the best practices that you can think of that would be best for your peers to get started?
This is Risa. I'll go first. And just because it's so recent for me, is that the best part was calling up anyone that you know, if you're in the community for a while and you can think of 20 or 30 people to invite together to have the conversation without another agenda, that I felt that was really exciting. And so when someone at the table said, well, this is long overdue, I was like, wow, this might be on the right track, and then people getting excited or not. So I mean, clearly we hope that that would be the case. But I think that having no agenda and no grant to write and to make something happen is always a really wonderful moment for all of us to have together. So, and it worked for us.
Zach or Amanda, do you have any thoughts or any advice for those who are wanting to get started?
I think my only advice is that the conversations are hard, they're difficult, and especially when you're working with communities who may have felt or may have been disenfranchised by institutions throughout the community. The conversation can get difficult, but it's important not to walk away from the table and not say, okay, this is too difficult, we can't tackle this right now, because just in the act of not walking away from the table, huge strides can be made in advancing this work. I think there are a lot of ways to get the work going, but I think once it's going, it's important to keep it going and not say, okay, well, this is something that we can come back to later once it feels less tense, once it feels less awkward, because it will always be uncomfortable at first, and I think it's an important process to go through.
Yeah, I mean, I would echo both of those comments, and and just add that, you know, place to start is just with what you're doing now, and having a conversation about, well, where, you know, what are we really doing, and have a candid conversation about, are we really working on issues that will, and strategies that will advance equity, and if we're not, what can we do about it? And I think just having the, you know, because I think that Zach is right. I mean, it can be challenging, especially if you're feeling like you may not be in a position to start the conversation, or that you may be the only one. It may just start with one other person, and continue to just try to open and have a dialogue, or maybe a few people. But you can start somewhere, and it doesn't have to be big, and it can just start with one conversation.
Wow, that's an important point to remember, Amanda. Thank you. I'm going to try to squeeze in one last question. So for our panelists, if you're answering this, try to keep it to about 20 seconds or less. But what other tools or resources have you used that might be useful to others? And I know each of you mentioned different tools, but if you could just sort of summarize what sort of tools you think are best in engaging in this work of health equity.
So I'll just quickly reiterate again, the National Equity Atlas is actually, that database comes from a couple years of work where we were being commissioned by organizations and government agencies to develop equity profiles, where we were creating basically reports and looking at over 120 indicators in a particular region. And we really felt like this was something that we needed to share and democratize with other people to, and this is maybe another good starting place, just going to the Atlas, going to websites. Another good resource is policymap.com, and just start looking at the indicators. Well, what does it mean to move on equity? What are the indicators? How do I best understand what's happening in my community or in my state? And then the second thing is, I know I put up on one of the slides a framework from the Multnomah County Health Department, and Multnomah County actually has come up with a fabulous toolkit and guide called the Empowerment and Equity Lens. And it's a set of not lengthy curriculum, but just some guides on how do you think about empowerment and equity both internally and externally. And so I would recommend that as a resource as well.
Sorry, Zach,
to reiterate, to reiterate one that I said, we use the MAP framework that is by NACCHO, and they also have a health equity supplement to that, which is even more useful to get people thinking about how to integrate health equity into community health improvement planning. And the other thing that my department uses is Robert Wood Johnson has a report called A New Way to Talk About the Social Determinants of Health. And we actually just yesterday had a conversation internally about the way we talk about social determinants of health and how the language it uses is really important to engaging people who need to be at the table to have those conversations. So those are just two tools that we use.
And this is Reese. I would just add that with Robert Wood Johnson, they have this free technical assistance service for up to a year for individual or groups that are forming. And so we tapped into that just by locking away. So that was as a nice addition to our resources.
Thank you. I just really want to thank all of our panelists that have been able to join us today. We are very grateful that you were able to share your expertise and your insights and willing to be candid about, these are conversations that need to happen. So thank you for sharing that. As I said before at the beginning of our webinar, both the recording and the slides will be made available to you all in a few weeks through email. I do also want to share a comment from someone on the webinar. For folks who are in Springfield, there is a Undoing Racism training that will be taking place March 27th through the 29th. And so I can send out a link to that information. Additionally, the Community Health Training Institute will also be having follow-up conversations and in-person trainings around the state to really follow up from today's webinar and to continue the conversation. To really be able to put some of these practices and strategies in place in your own communities. So we invite everyone who's on this webinar and folks that you work with, folks who you are engaging with around health equity to hopefully make yourself available to come to these trainings. It will be a full day, and we're expecting to really be able to dive into the work and to make health equity more actionable and not just a concept that we think about.
And Aaliyah, I just wanted to say, again, this is Steve Rodini. I wanted to thank Amanda, Risa, and Zach for your time and your thoughtful presentations. Building on what I heard, we've got to start the conversation somewhere. It's important to begin to ask the questions, and even more importantly, to continue to ask the questions. Folks identified some really helpful resources. I wanted to let you know at HRA we're developing an additional resource about integrating an equity framework into health improvement planning work, and we'll make that available to you all as you have signed up for this webinar, and that should be available hopefully in the next month or so. I also wanted to make sure to thank Aaliyah and Judy and Ben who do all the behind-the-scenes work here as well in terms of helping with this webinar, so thank you. So thank you all for your participation in today's webinar, and we hope to see you at a future training. Have a good afternoon. Thank you.
Thank you, everyone.
Thank you.
Bye.